although we recognise that vast numbers of patients have these recognised as a cause for fatigue, and therefore if we don't find another cause, at least it gives an option for treatment. And perhaps in the COVID era, it's very important that we are keeping our vitamin D levels up. If anyone's got any further comments on that, I would say generally on the filter function test, we do recognise that this group of investigations, which were decided at a national level, are a comprehensive and relatively expensive set of tests. They can be requested from one click of the button. But if you would rather, or you really feel strongly that you'd rather have a different set of tests or even some additional tests, then that's absolutely fine. As clinicians, it's important that you can make your own decisions about that. If you can, if possible, just elucidate why you made that decision and your thinking behind it, that will be very helpful as part of the referral. And particularly if there are delays in getting any of the tests, just to say I couldn't get this test or I didn't feel this test was appropriate, just say that in the referral and we will almost always accept that.
Thank you. Specific questions around tests. Sinapu's put something in the chat around platelets. Do you want to kind of speak your question out loud, Sinapu, to Andrew?
So the question was that I understand from the chat that raised platelets come up with an automatic alert on the system saying that this could be due to cancer, which is true. I think generally the truth, the answer is that whenever we see any abnormal result, as a clinician, we should try and explain that abnormal result and to come up with a rational explanation which we can document in the patient record. So if someone's got a raised platelet count, but actually it's been like that for the last 5 years, and it's only marginally raised, then perhaps that's constitutive in that particular person. If the person's recently had a bleed, for instance, then the platelet count may be raised from that point of view. But naturally, if the platelet count is raised in the context of significant symptoms, even if they're very mild and non-specific symptoms that would concern you, then yes, absolutely, that would constitute part of the reason why you would want to refer the patient to the RDC. Do we want to see patients in the RDC who are entirely well with no other problems whatsoever, purely on the basis of a raised platelet count? Probably not at the moment. I would suggest that would offer a good reason to send off an advice and guidance query to the haematology team. But very interested to hear from Vinay and Larissa about whether they've got other thoughts on raised platelet count.
Yeah, I agree. In isolation, I think a raised platelet count is probably something I wouldn't get concerned about, but it has to be in the context of a bigger clinical scenario, really. And like you said, advice and guidance is probably a useful pathway which you can use to discuss with the haematologist to get a bit of advice in a sort of more efficient way.
And sometimes also trending the results. So EMIS is quite good at providing a trend results layout for as a clinician, so that can give some a bit of a clue about whether this is new or whether there's a persistent change over time, and that obviously has different implications, so people might find that helpful. Staying on the topic of haematology, Rasha's asked a question earlier on in the chat around anemia and finding that anemia patients are often the biggest challenge, needing multiple inputs and referrals. I'm reading from her question. Do they qualify or need to go to upper GI first, or do they qualify for an RDC referral?
So it's very much recognised that anemia is a particular conundrum because it's got such a wide differential in when it's just the low hemoglobin in the first instance. My feeling is that one of the very important factors again in low hemoglobin is please don't start the patient on iron replacement therapy until you've established what the hematinics are. We do sometimes see a reflex treatment with iron treatment before we've actually got the hematinics, because obviously the difference between true iron deficiency anemia or deficiency of B12 or folate and anemia when you've got a when you're fully replete of those vitamins and minerals, then obviously those are two different conditions altogether. Patients who've got iron deficiency anemia on its own with no other symptoms whatsoever, which is unexplained, and I would just make a little plea that patients who are in their late menopause or late menstrual phase, so a 49-year-old, 52-year-old lady who is still having periods but they're light, who develops anemia, I think they should be investigated just as aggressively as a patient who's 56 in the same context. So if you don't know the cause of the iron deficiency anemia, that patient almost certainly needs an endoscopy and a colonoscopy or another lower GI investigation if colonoscopy is not appropriate. Generally, we do advocate that those patients could go to either upper GI or lower GI pathways. If you don't feel they're appropriate or you really feel they need to go to both pathways, then the RDC could be a reason to refer those patients. But most of the time, though, if the patient has not got complex problems, and generally if you know that that patient has got a normal endoscopy and normal colonoscopy, that's going to allow you to manage the patient in primary care without further involvement from specialists, then it may well be that either the lower GI or upper GI pathway would be appropriate. And probably in the older patient, perhaps the lower GI pathway, because they're statistically more likely to have a cecal cancer.
Thank you. And then someone else has raised a related point around ferritin being very common and difficult to know when it could be cancer. Of course, ferritin is a non-specific, acute phase protein, which is also difficult. So I don't know who wants to talk about ferritin. I can see Vinay nodding madly. So,
yeah,
but on it in alone, it wouldn't necessarily trigger a referral to RDC.
Yeah, I think a raised ferritin is an acute phase reactant, and in itself is not. It's not a case of it's cancer until proven otherwise. There's numerous possible causes for it, isn't it? And it comes back to taking a full history and understanding the full context of it and getting a trajectory of it. I think in isolation, it's not something that would concern me, but it really depends on the bigger picture. I don't know what you think, Larissa.
Yeah. So I would like to build on that, what Vinay said. I agree, especially about the ferritin. We have to be very careful during post-COVID era. As we know, it's very often increased in patients who suffer from COVID, and just by taking the history is actually extremely important to make sure that we're not referring because of the isolated results, and it could be due to, let's say, recent infection with coronavirus. We see elevated ferritin, I would say with no exception, in all patients who had the COVID infection.
Right, thank you. Tal, can I bring you in to ask your question, please?
Sorry, Claire, can I just point out the raised ferritin, very important to do an iron and iron saturation.
Yes.
Because I think the difference between ferritin with a normal iron saturation and ferritin with a raised saturation is very different. So obviously you are concerned about true iron overload if the saturation is over 55%, and also to do the liver function test, because fatty liver disease is a very common cause of raised ferritin.
Yes, thank you. Thank you. Tal, can I bring you in to ask your question?
Yes, I've had a patient in the past that I've ended up referring to, I think it was actually the lower GI, with a persistent iron deficiency anemia without any good explanation. And we've ruled out celiac and dietary causes and this and that. And at one point I went to advice and guidance, and the suggestion by a gastroenterologist was very much, you have to exclude the small bowel malignancy. And I found it quite back and forth to convince the consultant at the time, who was leading on the weak weight pathway, to get some small bowel imaging. So I'm wondering whether we should then go back to the original consultant, or would those cases warrant an RDC referral?
I think in my experience of that, in someone that has iron deficiency anemia with a negative bidirectional endoscopy, you would replace their iron and you would monitor their hematinics. If they increment, that's fine. If they do not increment and you're having to continually replace their iron, you would then worry about a small bowel source of bleeding. I think in my practice, and I would repeat an upper GI endoscopy, because there is a miss rate of about 7% of missed lesions in the upper GI tract, and then you'd investigate the small bowel by using what's called a capsule endoscopy. Small bowel malignancy is very uncommon. Very, very uncommon. And the other thing to think about is, in my experience, there are sometimes extra GI causes of iron deficiency anemia. So I've not often, but I have on occasion diagnosed renal cancers. So these patients should probably be not forgotten about. They probably ought, from a GI point, have small bowel imaging, probably with a capsule, and then maybe some cross-sectional imaging if that's negative. Personally, I think that would still be more appropriate for a GI person to see rather than RDC. But I'd like to see what Andrew might think of that, or if you have any other ideas.
Yeah, I'd agree with that. And essentially, it's probably a little bit naughty, really, of the specialist to be turfing it back to primary care without an option to refer back. Generally, in my practice, if a patient's older and has a negative bidirectional endoscopy, then yes, you may well consider repeating either the upper eye or lower GI investigation, because a colonoscopy can have a miss rate as well, and particularly one wants to look back and see what the quality of that colonoscopy was, and if there was poor bowel prep, one would definitely want to have a look back. It's entirely appropriate, and it fits in BSG guidance that the first port of call if endoscopy and colonoscopy is negative is to repeat them, and if they go back to normal and stay normal and otherwise well, then that's fine to stay in primary care. If not, then vesiocapsular endoscopy is usually the next port of call. The commonest cause of our deficiency anemia in this context is usually telangiectasia and other vascular lesions rather than the malignancy in the small intestine, and that may then need to proceed to double balloon enteroscopy for actual treatment of that lesion if that's the cause of the problem. But if there is a malignancy, that will usually identify it as well. We almost always, in the older patient, would not refer the patient back, particularly if they've been referred on a 2-way pathway. If they've got negative endoscopy and colonoscopy, other malignancy, as Vinay says, are not uncommon, both lung and renal malignancies in that context, and therefore I always do a CT cap before referring the patient back if we've got undiagnosed iron deficiency anemia in an older patient.
Thank you, that's very useful.
I noticed that the next question, Claire, is what's the best test for early pancreatic cancer, which is a subject very close to my heart, because I think I have a little difficulty with the NG12 guidance, because if someone really feels that from the history that the patient has they've taken that the patient is likely to have pancreatic cancer, and that is a strong likelihood on the basis of any of the symptoms or presentation features of cancer, pancreatic cancer, a CT cap is actually more appropriate than a CT abdomen. One of the things that I think differs between old style radiology and new radiology is the speed of the spiral scanners, and a CT scan of the abdomen starts at the lower chest and ends just above the pelvis. And if you include the chest and the pelvis in that scan, you're actually only taking about 2 or 3 minutes in the scanner to complete the investigation. Whereas if you don't identify the cause of the problem on the abdominal CT, then you may well need to do a repeat CT involving the chest or pelvis to identify the nature of the problem, such as weight loss, and therefore it's often best to consider a full chest, abdomen, pelvic scan rather than just an abdominal scan in that instance. And I don't know this is a subject of debate in radiology world, but most of them actually, when they think about it from a practical point of view, agree with that approach.
So that's interesting. Can I just ask then, so often if you speak to radiology when an abdo CT has been requested, even in secondary care, they tell us that they include the pelvis. Is your experience that they only include half of it, or they don't really include it?
Well, they do actually include the pelvis quite often, because they know that actually they might as well. So the difference between the request of a CT abdo and a CT abdo pelvis is actually very, very, very slim. So you're right.
Right. Okay. Thank you. Thanks. I hope that's helpful, Silimpu. Now, there's another question around fit, which is a bit separate, so I might answer that separately. Are there any other questions around the referrals in or to the RDC? Or perhaps I can ask the person who asked that fit question, are you worried, were you asking about the milligrams, the sort of levels of HB per milligram of poo? Is that the question, what the number is? I'm just trying, I've lost who popped that question in the chat.
Hi, sorry, that was myself.
Hi. Yeah.
Yeah, it wasn't more to do with that, but sometimes I struggle with, because now it seems to be a requirement to do a fit test before a lower GI suspected colorectal 2-week weight is sent. But yes, sometimes when they have frank bleeding, I struggle with that. So sometimes if you're suspecting hemorrhoidal bleeding, but you're thinking if there is a potential malignancy as well, are we likely to go back to the old pathway where sort of based on symptoms you could refer without the fit test, or we're going to?
I think that, no, I think for colorectal problems, you will be using the fit test. We'll share again. We'll try to put it in the chat, so when you access this recording, you can see it. But it'll have to happen. I can't add it in now. It'll have to be added in later. But when you look at the video, you'll find it in the chat. There is an original pathway for which splits DG12 and NG12 patients on how we're managing colorectal symptoms, and on top of that, the situation across London is the waters are a bit muddied because the central team introduced a COVID pathway, and we will in May be transferring in North Central London to an adapted pathway, and we've had one session, Joe's webinar on that, and we'll repeat that again once that's actually started. And there are some nuances to those numbers on the fit test and how we're managing that, but you're always going to need to do a fit test before referral, because it's so useful in terms of picking up things. And Ed Seaward, who's that has been the clinical specialist lead on fit for our area, will tell you that the evidence is very clear and shows. So if you think someone's also got piles and they're producing always or frequently blood in their poo, they need to use the fit test either on a day when they see no blood, or sample a bit of the feces that isn't visually contaminated with blood. And the stats show us that that's really quite effective in a discriminatory way, which one might not have expected. But that's what the research outcomes tell us. I hope that's helpful. Thank you. We've got 2 minutes before the end of our session. So what I think I'm going to say is that a really very big thank you to everybody and our panel, and we probably could have gone on forever. If you've got questions that haven't been addressed and you'd like to pop them in the chat now before you individually leave the session, then we will look at those and send that out as an FAQ. Just a reminder for our full sessions of education webinars that we're running as the Cancer Alliance. If all you have to do is register once, and I will ask Catherine to put that registration in the chat so that you can pass it on to other friends who may not know about it. Once you register once, we'll then invite you for the full series. Obviously you're here, therefore you've all registered, but if you can't remember where the link is to register, I'll ask, as I said, Catherine to put that in the chat. Thank you very, very much to all of our speakers, to Catherine, Ollie, Vanessa at the Alliance for helping us put this on. And if you want to do if you'd like us to do a repeat session on this, an extension, then again, just put that in the chat so we'll know about that. Okay, thank you very, very much.
Thanks very much, Claire.
Thank you, everybody. Take care.
Thank you.